All right. Hi, everyone. My name is Stephanie Suarez Gonzalez. I am the Clinic Partnership Manager for MAVEN Project. Thank you all for joining us today for today's session of a rash and joint pain by Dr. Elizabeth Lee. And with that, I'm going to pass it over to Dr. Lee to introduce herself.
Hi there, everyone. Thank you so much for being here, and I'm excited to be able to present this course for you. It's called a rash and joint pain. I am a rheumatologist, but I'm retired now. However, I graduated from Louisiana State University in New Orleans for a medical degree. And after that, I had my residency in internal medicine at Indiana University and fellowship in rheumatology at Duke University in North Carolina. Then after that, I came back here to Indianapolis and practiced with Indiana University Health Center, and for about 20 plus years. And then finally, I just retired about a couple of years ago. And I'm excited about teaching because doing my clinical practice, and also doing fellowship, I'm so much involved. I was so much involved with fellows and medical students and also clinicians. So without further ado, let's talk about this. Next slide. I have nothing to disclose. Next slide. So after you complete this course, MAVEN Project designates this live activity for a maximum of 1 AMA PRA Category 1 credit. And next slide. So this course is very interesting because after you complete this course, you'll be able to assess and differentiate common causes of a rash and joint pain in the outpatient primary care settings. And especially with you are in the front lines, having to see so many patients a day, it is important for you to recognize these cases. Then to develop an early diagnosis and treatment plan for patients presenting with a rash and joint pain, ensuring timely referral to subspecialists when it is necessary. Then you, in the process, will also analyze clinical presentation to identify systemic correlations between dermatologic, rheumatologic, infectious, malignant, and drug-related disorders. Next slide. So let's dive in. There will be 6 cases representing 6 different conditions. And let's do with case 1. So this 29-year-old woman just presented to your clinic, and she complained that she had joint pain for about 2 weeks. And she said about 3 weeks ago, she had a faint pink rash on her cheeks for several days, and then it went away. And then, but since then, she had persistent pain in small joints of the hands, her wrists, and knees. And she says she's a teacher. And a couple of the children in her classroom had flu-like symptoms and fever, headaches, and a rash. And the rash looked like this young boy. Slap cheek appearance, red cheeks appearance. Next slide. So what you do is you start going through this analysis of this case. How do I? There are guidelines to do that, and it's very simple. We're going to repeat this slide over and over again, just so we can, hone these skills. First of all, you ask timeline. When did the rash appear? She said about 3 weeks before the joint pain. Secondly, where was the rash and the rash appearance? It's mostly on her cheeks, facial cheeks, and it's a kind of faint pink rash. And next thing is, when did the joint pain appear? She said about 2 weeks, 1 week after the rash faded. And then which joints are painful? She said, small joints of the hands, the wrists, and the knees. So you can see right here, there's more than just one joint. There are small joints of the hands, multiple joints of the hands, the wrists, and the knees. So you have to think this is systemic. And then the next question you have to ask is, anyone else had the same sickness? She said, well, the children in her classroom, a couple of them had fever and headaches, and they have that slap cheeks rash. And then the next question is, are there other systems involved? Definitely, she has a skin rash. Secondly, musculoskeletal. She had joint pain in small joints, the hands, her wrists, her knees. And then what else? How about the heart, lungs, GI, renal, bone marrow, like blood dyscrasias, blood vessels, like vasculitis or occlusion? Is there anything involved in that? Or constitutional symptoms like fever, malaise, nausea, vomiting, or diarrhea? If you answer yes to these questions, she definitely has skin, has musculoskeletal, some joint pain. So you have to think, yeah, this is systemic. Next slide. Okay, before we dive into and do an analysis, let's do a real quick overview of the immune system, because this slide is so important in analysis of differential cases. All living creatures and living things possess an immune system to protect the living entity from an external environment and internal cell dysregulation. In particular, we're studying the human body. The human body was created with a marvelous immune system, having both an innate and adaptive immune system. And the immune system, as you see right here on this schema, the whole system is composed of the bone marrow, that's where the B cells are, the thymus, that's where T cells are. Then you have spleen, lymph nodes. We have chains of lymph nodes from legs, arms, all the way up to the neck and tonsils and adenoids. That's the whole immune system. So the immune system in the human body is designed to protect the body from invading pathogens, which basically is to fight infections against bacteria, viruses, fungi, spirochetes, mycobacteria, and more. Secondly, the immune system is designed to continuously monitor and destroy the body's neoplastic cells before their growth would lead to malignancies. And thirdly, but if the immune system reacts too strongly in these two actions, then it can cause inflammation and damage to normal cells of the body, leading to autoimmune disease or autoinflammatory diseases. Next slide. Okay, so at this point, with our patient, we have to ask ourselves, okay, this is a systemic illness, but what kind of problem is this? Is this, put on our thinking cap, is that an infection? Is that a malignancies? Is that an autoimmune disease? Is that a drug-induced disorder, which is rare, but it can happen? She said she had slap cheek rash, but it had faded. But she had persistent joint pain in her hands and wrist. And all the children in her classroom also had a rash with slap cheek rash. So you think this is some acute viral illness. Next slide. So we're doing a physical exam of this patient, this young woman. Her vital signs stable. There's no fever. She has discomfort in her hands and wrists due to pain. And her lungs, heart and lung sounds unremarkable. There's extremities, there's no edema. Skin, right now, there's no rash. But musculoskeletal exam, you feel her hands, and there's tender and there's some swelling in the PIPs and MCPs. The PIPs are these joints here. They're close to the wrist. And the PIP are the proximal interphalangeal joints, what's right here. The DIP, which is the distal, are these joints. But she has joint pain in the MCP and the PIPs and both wrists. They're swollen tender. The knees are tender, but there's no effusion, no swelling. So you draw some lab. And the labs came back as the CBC, the CMP are within normal limits. But she has a little bit inflammation. Her set rate is 30, should be less than 20. And so at this point, you think the differential diagnosis would be some sort of acute infection virus. The first one we think immediately is parvo B19 infection, especially with small children. Roseola, rubella, measles, group A strep, enteroviral infections. And then the other labs came back, parvo B19 IgM is positive, indicating this is an acute infection. But parvo B19 IgG is also positive, indicating that she had a past infection of the same virus. So most likely, this is parvo B19 infection. Next slide. Okay, a quick word about parvovirus B19 infection. The good thing about parvo B19 infection is usually self-limited. It lasts between 3 to 5 weeks and is mild in healthy people. The common symptoms is mostly in children. They have that rash called slap cheek rash, and we also call erythema infectiosum, and we call it fifth disease. Low-grade fever, headache, malaise, myalgia. In adults, they have joint pain and manifesting in hands, the wrist, knees, the feet. The rash is atypical. 20% is erythematous rash on the face, but 80% of the time, it is a reticulated or lacy erythema on the legs, like this example. On the legs, followed by the trunk and arms. But there are complications, especially in special populations. The first complication is called aplastic anemia, meaning it decreased production of red blood cells, especially in patients who have underlying blood disorders like sickle cell, hereditary spherocytosis, or patients who had a weakened immune system, who had cancer, leukemias, chronic HIV. And the second complications is during early pregnancy. There's a slight increased risk of miscarriage. It's called hydrops vitalis, which is severe swelling of a newborn baby. The diagnosis mainly is clinical with labs like parvo B19, IgM, and IgG. You get CBC, your CMP, your set rate, and then the treatment, most cases are outpatient, is to relieve symptoms. You use NSAIDs or acetaminophen, NSAIDs like ibuprofen, Aleve, Advil, over-the-counter, acetaminophen. But for complications like aplastic anemia or early pregnancy, along with parvovirus B19 infection, that it is safer to refer the patient to the hospital, to be inpatient and have subspecialty consultation like hematology if the patient has one of the cell or hereditary spherocytosis problem, infectious disease, and OBGYN if the patient is pregnant. Next slide. So parvo B19 infection treatment mostly is outpatient because most of the cases are mild, is to relieve symptoms. You can use NSAIDs over the counter, acetaminophen. Between 3 to 5 weeks, symptoms would go away and the patient gets better. But for complications like aplastic anemia or pregnancy with parvo B19, we have to be cautious, refer the patient to inpatient, and to be having subspecialty consultation, hematology, infectious disease, or OBGYN. Next slide. Okay, let's dive into case 2. This is an interesting, very interesting case. A 45-year-old woman presented to your clinic this morning, and she had joint pain in both hands and feet. And she said about 2 to 3 weeks. So, interesting thing, she just came back from a trip visiting family on one of the Caribbean islands. And she was there for 4 weeks. That's kind of an extended stay on the Caribbean island. She reported that after the first week on the island, she developed fever of 102, a red itchy rash on her face and hands like this picture. The rash slowly faded away 15 days after the first symptoms, so it lasts about a couple of weeks. But now she has persistent joint pain in the hands and feet since then. And the hands are swollen along the MCP. You see the wrists are slightly, and the PIP right here. Now she's been taking ibuprofen as needed, gave her some relief for joint pain, but she cannot sleep. Next slide. So again, you have to ask the same questions. Timeline. When did the rash appear? After 1 week on the Caribbean island, she had fever 102. Where was the rash in her rash appearance? Or was it on her face, her hands? Looks like a maculopapular red itchy rash. We just saw it. And when did the joint pain appear? 2 weeks after the rash faded. So which joints are painful? The hands and feet. So she had more than one joint of the hands and joints of the feet. Most likely it is a systemic illness. And you ask yourself, ask the patient, anyone else had the same sickness? They say no. Any other system was involved. Definitely she has skin problems, she had the rash. Musculoskeletal, she had joint pain. What about heart and lungs or GI or renal or bone marrow? Blood dyscrasias, the blood vessels power, vasculitis or occlusion. Or what about constitutional symptoms, fever, malaise, nausea, vomiting, and diarrhea? She definitely has skin, she has joint pain, and she has fever 102. Yes, it is a systemic illness. Next slide. So systemic illness, again, think about your immune system slide. Put on your thinking cap and say, okay, is this an infection? Is this a malignancy? It is an autoimmune disease, or probably some rare causes like a drug-induced disorders. Patient, in our case, had fever up to 102. She had a red itchy rash on her face and her hands. And now she had persistent joint pain in her hands and feet. And she spent about 4 weeks in the Caribbean islands. So this is most likely an infection, but think it is acute or subacute with travel infection. And Caribbean island, let's think chikungunya. Next slide. Okay, so maybe some of you have thought about or have seen or have dealt with patients with chikungunya. It's an African word meaning that which bends up. A quick history about it. It is a mosquito-borne virus. Outbreaks in Africa, Southeast Asia, the Indian Ocean, Southern Europe, and most recently in the Caribbean. First isolated in Tanzania in 1952. This is a kind of infected mosquito that we're talking about, the Aedes subspecialty, Aedes aegypti, or Aedes albopictus. So that which bends up means severe arthritis. In 2006, severe chikungunya outbreak happened on the island La Réunion, a French island in the Indian Ocean. It infected 1/3 of the population of 260,000 people, more than 250 deaths, mostly elderly and newborns. In 2013, the Caribbean island of St. Martin, 2014 in Florida, very close to home, more than 600 travel-associated cases across the US, Puerto Rico, US Virgin Islands, and the key gene in chikungunya is the lack of ISG15, which causes severe inflammation. In 2017, there's more than 2.6 million cases of chikungunya reported in the Americas. Between 14 and 17, there's more than 4,000 chikungunya cases reported among US travelers. Between 2018 and 2020, 340 US traveler cases were reported. In 2020, there are fewer cases because of the pandemic. So if you have a patient traveling from Caribbean, think first first on your list is chikungunya. There are all the viruses too, or all the infected mosquito-borne viruses, and we'll talk about that as a question. Next slide. Chikungunya, how do you recognize it? Clinical facts. Incubation period, 3 to 7 days. Very short, within 1 week. The common symptoms, fever, high fever up to 102, joint pain, bilateral symmetric. It can be imitating something like rheumatoid arthritis. It can be debilitating in hands and feet and the proximal joints. And the rash is maculopapular on the trunk and extremities, palms, soles, and face, like this, like the back of this person. Maculopapular, or this kind of rash, maculopapular, red, itchy, and it can be on the extremities. They are all the symptoms: conjunctivitis, headache, myalgia, no. And so you draw labs, the usual CBC, CMP, but you're going to see elevated creatinine, elevated liver function test, lymphopenia, low lymphocytes, and thrombocytopenia, low platelets. And the diagnosis is done by viral nucleic acid or virus-specific IgM and neutralizing antibodies, IgG. Unfortunately, these have to be done at state health department laboratories and commercial laboratories. If you have a suspicion for chikungunya, it has to be done by state health department laboratories. And the treatment, there's no specific antiviral treatment for chikungunya. So basically, rest, fluids, use NSAIDs, ibuprofen, Advil, Aleve, acetaminophen. Usually, you use it first-line therapy to reduce the risk for hemorrhage until dengue can be ruled out. And nowadays, there are vaccines for chikungunya. And if you go on the CDC chikungunya vaccine website, there are at least 2 vaccines now available for adults aged 18 years and older. Next slide. Okay, so in our patient, she has chikungunya, and she had persistent joint pain, and ibuprofen. She's been taking ibuprofen and Aleve over the counter, but that didn't help too much. So she needs to be seen by rheumatology for immunosuppression. Rheumatologists would use a combination of disease-modifying agents such as methotrexate and plaquenil and sulfasalazine, or sometimes we use a little bit of prednisone, low-dose prednisone. Next slide. Okay, now case 3. An interesting case 3. 40-year-old man who lives in Connecticut presented with right knee pain and swelling like this, like in this picture. And this has been going on and off for about 2 to 3 weeks. He reported no recent illness, no fevers. His right knee swelling is causing difficulty walking, and he's been missing work. But he says 6 months ago, he went hiking with his family in the woods. Within 2 to 3 days, he developed a rash on his back. It was red, targeted with central clearing, like this rash. It looks like a target, it's central clearing. And usually it's on the back because the patient doesn't see it. He presented in urgent care back then, and it was thought to be Lyme disease. It was treated with doxycycline, 100 milligrams of tablet twice a day for 10 days, and then the rash went away until the swelling of the right knee. Next slide. Okay, now same thing, we have to ask the same question. Timeline, anyone has the same sickness, all the systems involved. Timeline, when did the rash appear? 6 months before presentation of the knee pain. Where was the rash and the rash appearance? It was on his back, red, targeted, central clearing. And when did joint pain appear? 2 to 3 weeks ago. So there's a delay between the rash and the joint pain. So which joint is painful now? Which right knee? Anyone else involved with the same sickness? No. All the system involved. He definitely has a skin rash. He had musculoskeletal problem with the right knee. What about heart, lungs, GI, renal, bone marrow, or blood vessels, or constitutional symptoms, fever, malaise, or nausea, vomiting, diarrhea? So he has two systems, skin and joints. If you say yes, definitely this is systemic illness. Next slide. Okay, systemic illness, again, put on thinking cap on again. Is this an infection? Skin and joints. Malignancies? Autoimmune disease? Could it be a drug-induced disorder, which is extremely rare, but it can happen? Our patient, 6 months prior to presentation, had a red targeted rash with central clearing on his back. He was treated with doxycycline, which the rash went away. But for 3 weeks now, he had persistent pain and swelling of the right knee. And there's only one joint, monoarticular arthritis. At this point, you have to think, okay, possibly an infectious process, but it is a chronic post-infectious process. Next slide. Okay, you examine the patient. His vital sign is fine, but he has a temperature of 99.1, low-grade temp. Heart and lungs are fine. Skin, right now, there's no rash. The rash went away, but musculoskeletal exam, the right knee has an effusion, is slightly warm, and somewhat decreased range of motion. All of the joints have no problem with the normal limits. And extremity, there's no edema. The previous labs from the urgent care, when he went and saw for his rash, showed that Lyme test, ELISA test is positive, and the Western blots, IgM is 2 out of 3 bands are positive, IgG 3 out of 10 bands are positive. We have to think about Lyme disease. Next slide. Okay, Lyme disease. Quickly, let's think about Lyme. Lyme disease location mostly in the north.
Dr. Lee, can you hear us? All right, sorry, y'all. Give us a few moments here.
Okay.
All right, sorry, everybody. We are back, and I'm going to pass it back over to Dr. Lee.
I'm so sorry, everybody. Let's do it again. And I promise, I hope that this internet's gonna hold on. So let's do again a bacteria, Borrelia burgdorferi. The cycles, it started out with the eggs in the spring. They mature to larvae in the summer, and in the fall become adults. And then in the winter after the winter, this is the period of time that there's a high risk of infection for humans. The black leg ticks, also called deer ticks, can carry this bacteria. Not all species of tick can carry this bacteria, but immature deer ticks cause for Lyme disease. So once it's infected, if it infected the humans or a deer tick, then the next thing will become adults, and then the next cycle they lay eggs again, and the cycle will start again. So Lyme disease, the 3 phases. Number is an early localized disease that manifested between 3 to 30 days, and usually it comes with fever, chills, headache, fatigue, muscle and joint aches, and swollen lymph nodes may occur in the absence of a rash. And the rash with scent migrants, it happens between 70 to 80% of the time, between 3 to 30 days after the infection, and is averaging about 7 days. And it can reach up to about 12 inches or 30 centimeter or more across top. Next slide. So Lyme disease, the second phase is called early disseminated disease. It occurs between weeks to months after the tick bite. And this is a stage that you have to be careful because it can affect the heart, like carditis, 1%, neurologic, 15%, like Bell's palsy. You probably have seen that in your clinic. Musculoskeletal involvement is 60%, migratory arthritis. Skin, it can be manifested as multiple erythema migrans. Lymphadenopathy. In the eye, have conjunctivitis, iritis, vitritis. In the liver disease, hepatitis, or elevated liver function test, and then kidney disease. And then the third phase is the late disease. It occurs between months to years after the tick bite. Musculoskeletal exam, 60% untreated patients manifested as monoarticular or oligoarticular arthritis. And 10% has persistent monoarthritis, and usually it's the knee. In this case, the patient needs to be referred to rheumatology for treatment. It's rare, but it can happen. Peripheral neuropathy or cutaneous, more feel-like lesions, and usually it happens in Europe. Next slide. Okay, Lyme disease in the primary care settings. If a patient like this presents to you, so what do? Recognize Lyme disease phases. Is this an early localized, which is just the rash, the erythema migrans, or early disseminated? It can affect the heart, the CNS, or the joints, the skin, or is this a late disease? And secondly, refer to specialists. If it is a early localized EM rash, erythema migrans, we can give doxycycline for 10 days, 100 milligrams one time twice a day. Or if you cannot take doxycycline, you can use amoxicillin for 14 days or ciprofloxacin for 14 days. And if it is an early disseminated disease, which occurs weeks to months after the tick bite, and this can be a challenge because a lot of times we don't correlate the rash and the joint or the secondary manifestations. Then in this case, we have to refer to infectious disease, or if it affects the heart, cardiology, or Bell palsy, neurology. In late disease, which is months to years after the tick bite, and this is a little bit more challenging because we don't correlate between the rash and the joint pain, but it has persistent monoarthritis and usually affect the knee. These patients has to be referred to rheumatology because rheumatologists will use, first of all, they're going to tap the knee take the fluids out, and then they use disease-modifying agents. So our patient has late Lyme disease. He was referred to rheumatology for persistent right knee pain treatment. Next slide. Okay, case 4, very interesting case. This is a gentleman, a 55-year-old man. He is a construction worker. He had not seen a doctor in many, many years. And then he just presented to your clinic. And he said, I have severe joint pain in small joints, the hands and the knees for many, many months. And he attributed the pain of his joint pain to hard work at construction sites because he traveled across states to construction sites. He takes naproxen, Tylenol is needed for joint pain. And specifically, he does not like to take medications. He also complained of a rash on his legs that just appeared about 2 to 3 weeks. These are red dots, non-painful, they're itchy, like this. Red dots, non-painful, itchy. And on further inquiry, he said, well, I was diagnosed with hepatitis C about 10 years ago. I had seen a hepatologist, but I did not want to follow up with treatment because of my job. He's a smoker, a pack a day, 15 years, alcohol user, but no illegal substance abuse, and past surgical history, not applicable. Next slide. Okay, same thing. We have to ask the same question, timeline. When did the rash appear? It's about 2 to 3 weeks ago. Where was the rash? The rash appearance, legs, red dots, non-painful, itchy. When did the joint pain appear? It was months. And which joints was painful? Small joints, the hands and the knees. So this is more than one joint. It's most likely systemic illness. So next question is, anyone else has been, involved, had the same sickness? No. All the system was involved, mostly the skin. Okay. Okay, I got it. All the system involved. He had a skin rash. He had musculoskeletal problems, joints involved with the hands and the knees. And is anything else like the heart and lungs, GI? Yes, GI, because he had untreated chronic hepatitis C. Renal, bone marrow, blood vessels problem, not really. Constitutional symptoms, fever, malaise, nausea, vomiting, diarrhea. Presently, he does not have complaints about these. If we answer yes to more than 2 questions, then definitely this is a systemic illness. The patient has skin rash. He had joint pain. He had untreated chronic hepatitis C. We think systemic illness. Next slide. Okay, systemic illness, thinking cap again. Is it infection, malignancies, autoimmune diseases, drug-induced disorders? Our patient had untreated chronic hepatitis C for more than 10 years. He had joint pain in the hands and knees for months. And presently, he's just presented with itchy red rash, confluent on both legs. We have to think, okay, think infection, chronic hepatitis C infection. Next slide. Okay, we examine the patient, physical examination. His vital signs stable. He's dentalist, unkempt, no apparent distress. Heart and lung sounds good. Abdomen sounds fine. Bowel signs positive. Extremities, there's no edema. Musculoskeletal exam. He has slightly deformed PIPs and MCP. These are the MCP, these are the PIPs. There's no swelling, but tender when you squeeze the joints of the MCP and the PIP rows. Bilaterally and symmetrically, so on both sides. The knees show bony hypertrophy, but there's no swelling. He had full range of motion. And skin, lower extremity, of the lower extremity had a red rash, hyperpigmented lesions, non-blanchable, confluent, itchy, and some pain, like this rash. And when you use the word non-blanchable, meaning that when you push on it, it doesn't become it doesn't become white. It's still red. It means that this is vasculitis, blood vessels had been broken. And you draw some labs. Rheumatoid factor is 38. Now that's interesting because rheumatoid factor should be less than 14. Anti-CCP, the second rheumatoid factor, is negative. Complement C4 is low, 6. C3 is normal. But he has elevated liver function tests, elevated SET rate at 46, CRP is 3.2. So he definitely has chronic and acute inflammation. Hepatitis B, hepatitis C, antibody positive. HCV RNA is 1.2 million copies, highly positive. Hepatitis B, antibodies negative, HIV negative, VDRL negative, and RPR negative. And you do a biopsy, and this comes back to be leukocytoclastic vasculitis. So this is chronic hepatitis C infection with extrahepatic manifestation. Extra meaning outside of the liver manifestations. Next slide. Okay, chronic hepatitis C infection. Let's quickly talk about it. Following an acute hepatitis C infection, between 50 to 85% of the patient will progress to a chronic hepatitis, usually slowly progressive. And among the patients with chronic hepatitis, 5 to 30% will develop liver cirrhosis over a period of 20 to 30 years. For extrahepatic manifestations of chronic hepatitis C, the manifestations are number one, essential mixed cryoglobulinemia and lymphoma, or you have renal problem, autoimmune disease like thyroiditis, dermatologics like PCT, porphyria cutanea tarda, leukocytoclastic vasculitis, diabetes. And so you ask yourself, when do I suspect MCS, which is mixed cryoglobulinemia syndrome, a very common manifestation of chronic hepatitis C? If the patient has arthralgia, joint pain, myalgia, muscle pain, frank arthritis is actually rare. And it manifested mostly in the MCP, the PIPs, or small joints, the hands, knees, ankles, a palpopurpura, which is a rash, non-blanchable vasculitic rash, and possibly skin ulcers. Elevated rheumatoid factor, low complement C4, hepatitis C or B or HIV settings. So we have to suspect mixed cryoglobulinemia syndrome in a setting of hepatitis C or B or HIV settings. Next slide. Okay, chronic hepatitis C infection with extrahepatic manifestations. Our patient has untreated chronic hepatitis C with extrahepatic manifestation as mixed cryoglobulinemia syndrome. He had bilateral symmetrical arthritis in her hands and knees. He had a palpopurpura diagnosed as leukocytoclastic vasculitis after biopsy on his extremities. So what do? We have to refer the patient for treatment, hepatitis C treatment. And in fact, if you treat hepatitis C, joint pain and the rash got better. And nowadays, there are more treatment for hepatitis C for our patients. Or also refer dermatology to confirm the leukocytoclastic vasculitis to a skin biopsy. And finally, refer to rheumatology if it has persistent joint pain for joint pain management. And usually rheumatologists will use disease-modifying agents, and sometimes we use biologic agents like TNF inhibitor. Or if the patient cannot be waiting for all of these consultations, because sometimes can take months, the patient needs to be inpatient for a workup and immediate treatment, or as fast as possible treatment. Next slide. Okay, case 5, very interesting case. A 39-year-old man, he's a factory worker. Now he's had presented to your clinic with pain in his right toes for months, like this. This right toe is swollen, red, and it looks like a sausage. It's worse for the last 2 months. He could not walk on the factory floor due to pain. And he's been taking the naproxen 200 milligrams, 1 time or twice a day, as needed for pain. So, and then he said he had rash on the external surface of both elbows and knees since his teenage years, like these. It's a red rash, kind of a scaly and white on the top. Social history, he smoked cigarettes 1 pack a day for about 10 years, occasional beers, no illicit drugs. And he also mentioned that his father and brother both have psoriasis. Next slide. You examine him, and vital signs fine, no apparent distress. His heart and lungs are fine, abdomen is fine, extremities no edema, and musculoskeletal exam. The right swollen is red swollen right, second, third, and fourth toes, like these. And they look like soft digits. They are swollen and they're red. Looks angry. And there is what we call periungual erythema around the nail bed. It is really swollen and tender. Looking at his nail, there's something called pitting. It's just like you take a really sharp object, a pen, and you make a pock mark on the nail bed. And it's pitting with onycholitis. Onycholitis is fungal infection. You look at his tendon, the left Achilles tendon is swollen, tender to palpation, and the skin, it has scaly white rash on the external surface of both elbows, knees, on his back, and his scalp, just like this, on the back and the scalp. And if you see this on the back, also make sure that you look at the gluteal crease between the gluteal area, and you would see a typical mark of that rash. Okay, next slide. Okay, same thing. We need to ask the question, timeline, anyone else has the same sickness and other systems involved. His rash, so it looks like psoriasis, at least for 20 years. It's a chronic problem. Where was the rash in appearance? It's basically elbows, knees, back, scalp, fingernails. And what about the joint pain? It's been going on for months. And the joint pain, the swollen toes, and it's swollen. Anyone else have the same sickness? No. Other systems involved. It had skin, it had nails, joint pain problem, Achilles tendons problem. And what about heart and lungs and GI and renal, bone marrow, blood vessels, and constitutional symptoms? If yes to more than two, definitely think this is systemic. But in this case, it's more than 20 years. So it is a chronic systemic illness. Next slide. Okay, systemic illness, the same thing we have to ask ourselves, is it infection, a malignancies, an autoimmune disease, or drug-induced disorder, which is rare? He has psoriasis. Our patients had psoriasis for 20 plus years. Now he's presented with swollen toes for months, and his left Achilles tendon is swollen and very tender. He can't function. Definitely this is chronic, it is systemic, but it is not infection. Most likely it is an autoimmune disease. Next slide. Okay, lab work. CBC showed he has slight anemia from anemia of chronic disease. CMP is normal within normal limits, but he has elevated set rate in CRP, both chronic and acute inflammation. His HLA-B27 is negative, IGRA, which is TS, is negative, hepatitis B negative, hepatitis C negative, HIV negative, and VDRL negative. Most likely, this is psoriatic arthritis. Next slide. Okay, quick word about psoriatic arthritis, because many times we will be challenged if we see so many different signs all over the skin or joints of a patient. Prevalence. Female and males is about the same, 6 out of 100,000 per year. 1 or 2 per 1,000 in general population. The timing onset, psoriasis can precede the onset of arthritis about 7 to 8 years. So you have psoriasis first, and then 7 to 8 years later, you can have arthritis. Or the arthritis precedes the skin disease in about 7 to 15% of patients. Or you can have both skin and joint manifestation at the same time, about 15% of the patients. The clinical manifestation of psoriatic arthritis is peripheral joints, like what we saw, swollen joints of the hands and toes, axial skeleton, SI joint. This is important because patient can complain of back pain, hip pain, shoulder pain, dactylitis, meaning sausage digits of the peripheral joints, skin and nail, like nail pitting, odocolysis, skin, we saw that psoriasis, entheses, inflammation. This is interesting. At the site insertion of tendons, ligaments, and synovium into bone. For example, the Achilles tendon, the plantar fascia at the bottom of the foot, and the pelvic bones. Bone effusion across the joint, which is called ankylosis of the spine, peripheral joints of psoriatic arthritis patients, and ocular involvement. This can affect the patient too. Uveitis, conjunctivitis, in psoriatic arthritis patients. So you draw labs, ANA, rheumatoid factor, anti-CCP, and elevated, patient most likely have elevated sector rate and anemia or chronic disease. SLEB27 can be associated with psoriatic arthritis, and SLA-C06 can occur about 42% with PSA, 17% in the general population. Next slide. So our patient has long-standing psoriatic arthritis with active disease, chronic and active. And he is not functional. His joint pain is so painful that he can't work, and his rash is debilitating. So we have to refer the patient to rheumatology for further workup in immunosuppression. Nowadays, rheumatologists would use disease-modifying agents. We will start with methotrexate, and then we add on biologic agents like TNF inhibitors or IL-6 inhibitor or IL-17 inhibitors. And so there is, the point is, if you can reassure the patient that the patient can have a treatment that will put him back on the and he can go back to work. So that's reassurance is important for the patients. Next slide. Okay, last case and very interesting case. Case 6, 47-year-old man has multiple present to your clinic with multiple tender erythematous tuberculous macules and pustules on his palms and lower legs that looks like this. Tiny, but very painful. And right there. He had fever, but he went away, had malaise. And now he had joint pain in his wrist and the right ankle for about 3 days. He said there's no history of urogenital symptoms. And his lab showed he had leukocytosis of 17.3. Definitely you think this infection. Increased CRP of 30.74 and acute inflammation. Skin biopsy of the skin biopsy showed he had leukocytoclastic vasculitis. Blood cultures showed he had gram-negative diplococci, subsequently identified as Neisseria gonorrhea. So he was concerned about STI. The patient reported having unsafe sexual behaviors about 2 weeks ago. And so screening tests happened for syphilis, chlamydia, HIV were all negative. Next slide. Okay, same thing. We need to ask the same question. Timeline. When did the rash appear? 1 week ago. Where was the rash and rash appearance? Tender erythematous tuberculous macules and pustules on his palms and lower legs. What about the joint pain? About 3 days ago, pretty acute. Wrist and the right ankle. So it's more than one joint, systemic for sure. Anyone else had the same sickness? No. Other system involved. Skin, yes, you got a rash. Musculoskeletal, yes, you got joint pain. Is it heart, lungs, GI, renal, bone marrow, blood dyscrasia, blood vessels problem, vasculitis, occlusion, or constitutional symptom? They have fever, malaise, or nausea, vomiting, or diarrhea. If we answer yes, we think systemic, this is an acute infection. Next slide. Okay, systemic illness, same thing. Infection, malignancies, autoimmune disease, or drug-induced disorders, which is a rare thing. The patient presented with tender macules, pustules on his palms and lower legs. He definitely had a rash. He spiked fever. He had elevated white count. He had CRP elevation. So blood culture positive for Neisseria, not gonorrhea. And he's got tender wrist and right ankle for 3 days. This is an infection, an acute infection. So you have to think acute disseminated infection. Next slide. Okay, disseminated gonococcal infection, DGI, presenting as the arthritis dermatitis syndrome. DGI results from the bloodstream dissemination of Neisseria gonorrhea, typically developing within 3 weeks of primary mucosal infection. And the classic triad is skin rash, polyarthralgia, tenosynovitis, and is termed arthritis dermatitis. 70% has migratory arthritis, asymmetric polyarticular pain, tenosynovitis in small joints. 67% has tenosynovitis and 40% has purulent arthritis. So we have to be careful about this because it can be a problem if that ankle become purulent arthritis. Dermatitis, 67%. Cutaneous lesions are scattered, small-sized pupic macules on palms and soles. And fever, 63%. GU symptoms, 25%. DGI, disseminated gonococcal infection, is mainly confirmed by culturing gonococci from blood, synovial fluid, or skin lesions. The culture of synovial fluid and skin lesion are mostly negative, but positive blood cultures are identified in 50% of the cases. And the CDC recommends dual antibiotic therapy, ceftriaxone plus azithromycin for DGI. Next slide. So DGI presenting as the arthritis dermatitis syndrome in the primary care settings in your situation. If you see on the front line, you see patients in the clinic, is early recognition of DGI. And you see the rash and the joint pain, and you see the typical rash with DGI is raised antenna immediately. The patient needs to be referred to inpatient for further workup and treatment with IV antibiotics. Next slide. Okay, well, thank you so much. I apologize for the interruption right in the middle, but I'm ready for questions.
Not a problem, Dr. Lee. It definitely happens. But as mentioned, we have some time for some Q&A. If anyone is able to stay on, go ahead and drop those questions into the Q&A or the chat, and I'd be happy to ask Dr. Lee to answer them. Everyone saying thank you.
Thank you, everyone. Thank you so much. Just ask question, or if you think about it, because there are a lot of information today. If you think
Yes.
about it, just email me through either Stephanie or Kristen,
Yeah.
and I'll be more than happy to give you more, leads or links or explanations.
I'll give it another minute just in case anybody's typing.
Okay.
All right. Well, it doesn't seem like there's been any questions. I will agree with everyone. This was an excellent presentation, so thank you, Dr. Lee. As mentioned at the beginning, remember that once you exit out of this, your CME survey will appear, and that's how you will get that credit. So please make sure that you do complete that. If you have any questions, don't hesitate to reach out to a MAVEN team member, and we'd be happy to get you taken care of. But outside of that, I will let everybody go. I hope you all have a wonderful rest of your day, and thank you again, Dr. Lee.
Thank you, Stephanie, and Chris. Thank
You're
you, Kristen.
welcome.
Thank you so much.
You're very welcome. Have a good day.
Oh, yeah, you too. Thank you.